Alright, so this next talk is a talk I call the nodules talk. I call it that for a couple of reasons. One is to mock breast imagers, and anytime I can take a shot at the breast imager, I love the breast imagers. My friends, the breast imagers. Somebody's got to read that shit. Glad it's not me. So, but yeah, so nodules. So what does that mean? That means both benign and malignant stuff. So let's get into that. Let's get in the mud with that. So here we go. Here's the first case. So the very first book that I read in radiology was that pink book Clyde Helms put out, Skeletal Fundamentals. It's actually just the chapters out of Branton Helms. He just like chopped that out and like put a different cover on it and then tried to sell it a second time. Can't blame the guy, but it's well written. It's an excellent book. The dude is one of the best educators in radiology, no doubt about it. He's the second best educator. We all know who number one is. So, so he has this thing that he does for different age groups for different lucent lesions or lytic lesions in bones. And the one that I think that's the most useful is the epiphyseal differential. So that's going to be this thing here. I know it's basic, but as we're talking about here, all right, metaphysis is up there. So when it's all the way to the tip here, then we're talking about epiphyseal differential. So he does it over 40 and under 40, and here's the list under 40. Here's the list over 40. I just want to point a few things out. So Mets and myeloma, they make the list when you get old, right? You're not getting myeloma, despite what some inferior educators will tell you. You're not getting myeloma for the purpose of multiple choice. That shit is not going to happen under 40 on a multiple choice exam. They give you an age. This is not happening under 40. It is happening over 40, and so are Mets. Yeah, you can have Mets under 40. You can have neuroblastoma Mets, but they're usually lucent bands, and for the purpose of multiple choice. That's the way I would think about it. Geodes also, obviously, you get older, you get in that situation where you're getting geodes. Infection is on both lists. Notice that you're never too old to get infection. You're never too young to get infection. And the giant cell tumor is on both lists because you have to have a closed aphysis. But I would really think about giant cell tumor and more in this category. So how do I remember the under 40? This is how I do it. AIGC. I don't know if you remember this. It was in the news a few years ago. AIG was this evil corporation. So the four horsemen of the apophysis, those guys are bad, right? So, and AIG and the C's for corporation. So ABC, infection, giant cell tumor, chondroblastoma. Remember that the physis has to be closed for giant cell tumor to show up. So there's another entity, and this is a great opportunity for trickery with regard to multiple choice, is this so-called epiphyseal or apophyseal equivalence. So these are things, other bones that occur in the body that you need to know that same differential for. So calcaneus is the classic one, patella, carpals and tarsals, and trochanters. So if you see a lytic lesion in any of those bones, go back to your AIGC differential. So remember that. All right, here we go. What do we got here? Lytic lesion. It's epiphyseal, right? All right, and it is, physis is closed. I'm not giving you an age. I'll just tell you they're under 30. Huh, what is that? That's a lung cancer there, right? So that has to be an aggressive thing. This is a trick. This is an old school trick. So giant cell tumors are so-called quasi-malignant. Now, up to 5% of them can actually have pulmonary mets. Now, they're still curable by resection, but don't get tricked with that. That is old school trickery. Old school trickery. We're too good for that. Remember, 60% of GCTs occur at the knee. All right, they're eccentric. What do I mean by that? I mean they're not in the middle. They're off to the side. They're off to the side. The physis is closed, okay? So what are the things you need to know about giant cell tumors? They've got rules. This isn't numb. There are rules. So the first one I've said a bunch of times, the physis must be closed. The other two I haven't mentioned yet, but we'll go back and look at it again. The border is not sclerotic, okay? It's not a thick sclerotic border. Sometimes you'll see a really tiny thin one, but it's not a thick sclerotic border. Another thing is that it's always abutting the articular surface. So let's look at this thing again. See that? A little bit of thin sclerosis there, not really down here. Okay, so that's not really a disqualifier. It's abutting the articular surface. It's eccentric. Physis is closed. Thin sclerotic border. Giant cell tumor. Quasi-malignant. 5% of the time they can have a lesion in the chest. These things also, if you cut them out, you've got to do it with an in-block resection. You can spill these things, and you can end up with a whole bunch of them recurring. So just think about it like that. Quasi-malignant, wide resection margins. All right, another one. You see these things all the time, right? It's an enchondroma. It's a good look for it. Arcs and rings, speckled chondroid matrix. So the thing to know about enchondromas, there's probably two things to know. When are they going to be a cancer, right? So things that I use, number one thing is this. Pain. Low-grade chondrosarc versus an enchondroma. Enchondromas are not supposed to hurt. Cancers can hurt. The other thing to think about is the matrix changing. So if you're following them over a course of time and that internal matrix looks like it's changing, that's a suspicious thing. Okay, so interval change in the matrix. Obviously, if it's a soft tissue mass or something like that, that's highly suspicious. So no peristitis, no pain for an enchondroma. Pain, think cancer. So the other thing to think about with these is that, so let's look. See this? See that? Those are actually the same thing. They're both enchondromas. Why they look completely different, I can't tell you exactly why they look different, other than the fact that in the hands and in the feet, they're lucent. They do not have that arcs and rings appearance. So in the humerus, they look like that. In a finger, they look like that. And they're actually the most common lucent lesion in the finger. And by finger, I mean they're usually actually in the metacarpal like this. So, but this is what they look like. This one's got a little fracture through it. But in the fingers, or in the hands, they're totally lucent. So what about these two guys? These are enchondroma syndromes. And they're both rare as hell. Marfucci's is incredibly uncommon. I have a theory that there's only been one case of it ever. But they are very, very rare. So Ollier's is a bunch of hand enchondromas. Marfucci's is also a bunch of hand enchondromas. The difference is that Marfucci's has hemangiomas, which will look like phlebolus, and it has an increased risk for cancer. So how do I remember that? I remember that Ollier's is only enchondromas, and that Marfucci's has more than just enchondromas. It also has cancer and the hemangiomas. So there's more going on with Marfucci's. Ollier's is only enchondromas. Okay, so fluid levels here. There's a classic differential for this. The first thing you should think about is ABCs. The second thing you should think about is osteosarcoma, specifically telangiectatic osteosarcoma, and then giant cell tumors. So ABC first. Single best answer, ABC. Telangiectatic osteosarcoma or giant cell tumor, or the other things that could be in the differential, and the way that would be asked would be, which of the following is not a differential kind of deal? These are the classic three. ABC is the most classic. All right, this one here, this is an ant mini. This is the so-called shepherd's crook thing. If you were in Afghanistan rounding up your sheep while you're illiterate, illiterate self is in Afghanistan evading the Taliban or joining it with your shepherd's crook. That's what that would look like, and that is fibrous dysplasia. So what does fibrous dysplasia look like? And, I sung praises of Clyde Helms earlier in this lecture, but I'm going to say some less nice things about his text. When he goes on to discuss fibrous dysplasia, I remember being frustrated when he was just like, it just looks like itself. When you see it, you'll know it. It's like, that's the most unhelpful thing ever. You got a book called Fundamentals here. This is for first-year residents. They haven't seen shit. Why don't you just say the most classic description, which I'm going to now say, which is a long lesion and a long bone with ground glass matrix. How about you say that? Long lesion, long bone, ground glass matrix. Long lesion, long bone, ground glass matrix. Okay? So it is variable in reality. For the purpose of multiple choice, it's a long lesion and a long bone. What do I mean by long bone? I mean like a femur or a tibia or a humerus. A long bone. Again, there's no pain, there's no periosteal reaction, and the matrix is ground glass. A really good ground glass case right here. Okay, this is a classic thing. So there are both monostotic and which single lesion or polyostotic multiple lesion forms of fibrous dysplasia. The polyostotic ones tend to be more common in the skull and the face. I think about that. I don't know, we're going to have a syndrome I think I talk about, but McCune-Albright syndrome that has like the face full of fibrous dysplasia. It's the girl that can't get a date to the prom. Really, really horrible, disfiguring thing. That's the polyostotic ones. Monostotic ones, rib is actually the most common. If it's in the pelvis, it's also in the ipsilateral femur. That's a thing to remember too. Not necessarily the other way around. So if it's in the femur, it's not necessarily in the pelvis, but if it's in the pelvis, it's usually in the femur. So I mentioned McCune-Albright. So this is the precocious puberty, cafe au lait spots, that also has polyostotic fibrous dysplasia and tends to be all over the face, okay? Maselbrod is a less commonly known syndrome, but it make a great distractor because they both start with an M, and they both have polyostotic fibrous dysplasia, but Maselbrod has soft tissue myxomas. A Z is almost an X and a Y, X, Y, Z, X, Y, Z, Z for Maselbrods. So if you can remember myxomas, X, Y, Z, Maselbrod, and it's not precocious puberty. Like this one, you probably remember. This one was like a step one thing that was often, at least it seemed like it, where I went to med school, that showed up a lot on multiple choice tests. All right, so here's another. This is a classic look here. Classic look. We've got a lytic lesion in the humerus with a fracture through it. Anytime you see this, you need to immediately think solitary bone cyst or unicameral bone cyst. This is one of these things that typically happens prior to the age of 30. Classic look in the arm. It can also be shown classic look in the calcaneus. Something like this. Oh, something like that. So remember, the calcaneus is also special in that it's one of those epiphyseal or apophyseal equivalents, right? So you're thinking about your AIGC differential anytime you're looking at the calcaneus as well. All right, this is a good one. Classic look. So I want to point out a few things here. So there's a whole bunch of these sort of exostoses, and notice the direction that they're pointing. This way, this way, this way. See how they're pointing away from the joint? Okay, that's something that's important. So these are osteochondromas, and there's multiple. So multiple hereditary exostoses. The thing you need to know about them is that an osteochondroma is a benign thing, basically, but has a very, very small risk of malignant conversion, and it's based on the thickness of this cartilaginous cap. Now, if you've got more of them, then you have each one of those like small percentages add up. So basically, just knowing that they are at increased risk for cancer. Another thing to know about this is that with regard to osteochondromas, which are very common, you would get an MRI. The marrow cavity is contiguous with that thing. So there's a contiguous marrow. That's a thing that matters with these two. And then the last thing is that they all point away from the joint. So what if they point towards the joint? So there's an entity called Trevor's disease, and they tend to originate from the epiphysis and point in towards the joint. Trevor's. It's a zebra, but it is a thing that happens. All right, here we go. This is a so-called blade of grass. And what I'm showing here is, notice that this is sort of lucent, and then this is more sclerotic, like it's a pushing edge. See that here, lucent. That's sort of, some people say that looks like a flame. Some people say that looks like a blade of grass. Here's another look, same entity. Notice that hemipelvis is sclerotic relative to this side. This is a classic look on a bone scan, same patient. Different patient, same disease. Notice that the bone is expanded and the trabecula is thickened. There's nothing else that does that. MR showing this thickened trabecula here as well. So this is Paget's. Paget's is common. It's a lot more common than most people realize, and the way that I remember the epidemiology on this is 4% at 40, 8% at 80, so the older you get, the more common it is. It has phases, lytic, mixed, and sclerotic, just like fibrous dysplasia actually has sort of similar phases. It's usually multiple. Pelvis is the most common involved. Fibula is the least common involved. Some people say that it never occurs in the fibula. It's probably a case reported somewhere. Another piece of trivia that you need to know is that the, quote, most devastating or the most bad complication to know is the formation of a secondary osteosarcoma, which has the worst prognosis of all the osteosarcomas. Osteosarcoma is bad. It's especially bad when it's a secondary osteosarcoma. Paget's is known for that. All right, speaking of bad things, what we got here is a giant chest wall mass, and I sort of want to point out, if I can convince you, that there's maybe a little ring there, an arc. So this is a chondrosarc. Likes flat bones. A rib is a flat bone. Proximal tubular bones. It's typically in an older person, and they're common also, like 20% of malignancies. So here's another look. This so-called chondroid matrix, because we're talking about a chondrosarcoma, so it's a chondroid thing. So people will tell you to look at the matrix, and this is what a chondroid matrix looks like. Stippled, broken arcs and rings. These are all sort of the things that you think about. So what the hell does that mean? Like a ring, arc, like a broken ring, so something like that's broken, or it's like sort of like this kind of stuff. Like if you would get down in there and squint, there's an arc right there, right? There's another arc. That's chondroid matrix. So what are the risk factors? Paget's disease can cause other kinds of cancer, not just osteosarcs. Anything that has a cartilaginous name to it. So remember I mentioned before multiple hereditary osteochondromas, and the chondromas in themselves have a very small risk. Marfucci's and Alier's less than Marfucci's. Remember, Marfucci's is more for malignant. I'm not even going to mention that. I shouldn't have put that in there. So here's the next case. Squint and take a closer look here. This is a so-called Codman's triangle. Notice how the periosteum is a wide zone of transition. That's a bad thing, and we've got this thing that's sort of lifting up like that. So what do I mean when I say wide zone of transition? So when you see a lesion, let's say this is a lesion. If it's got a well-defined edge, like you can draw a pencil around it, and you can say, oh, there we go. That's like a thin zone of transition. That's a benign thing. Wide zones of transition would be something like this, where it's sort of tapering from white to gray to less gray to less gray as it comes out like that. Basically, bones are stupid, and they don't know how to do anything other than to absorb and make bone. and it's having trouble keeping up with this aggressive process. So you see that in two things: cancers and then infection. They're both aggressive, so the bone, it's not slow growing, it can't keep up with it, so it's got a blurred, like, sort of towards the end. So if you got an MR, this is what it would look like. We've got plain film often underestimates the extent, and that's one of the reasons you would do MRI, is to see how much of the bone is involved for pre-surgical planning. So conventional osteosarcomas are bone-forming tumors. So if you actually see bone being made in an aggressive way, that's an osteosarcoma. Long bones are preferred, tibia, femur. It's a metaphyseal thing. I like to think about that as a blood flow thing. So this part of the bone here, this part of the bone here. Diaphyseal things tend to be more Ewing's if you're going to go straight with malignancy. So Ewing's, diaphysis, osteosarcoma, metaphysis. If you're not sure, always pick metaphysis for as far as aggressive stuff: infection, metastasis, regular osteosarcomas. Some people will call this a septic tank because of that. All right, so younger, 10 to 20 years old is the most common age. So if you notice that there's a pneumothorax there. So when osteosarcoma likes to met, it likes to met to the lungs. And when it mets to the lungs, you have spontaneous pneumothorax. So this is a classic gamesmanship for osteosarcoma. Is I'm 15 years old. I'm in that 10 to 20-year-old age. I've got leg pain. Maybe it could show you a bone scan that shows you a hot thing there, or plain film with aggressive. And then suddenly short of breath with this. What does that mean? It means you got a met to the chest, because osteosarcoma mets cause spontaneous pneumothorax. So how do they do? They're typically treated with surgical resection. Chemo is all given as well for micromets. Present but not often detectable. These are bad. Conventional osteosarcomas are bad. They kill people. It's that chromosome 13 RB suppressor gene, bad juju. That's why you see people who have retinoblastomas, which is also RB suppressor gene, chromosome 13, they get radiation to their face for that. They end up with facial osteosarcomas because they're already set up to get them. So chromosome 13, bad juju, RB suppressor gene. Okay, here we go. So here's another bone-forming thing. Also, I want to point out that there's a little cleft right there, maybe. So this is another bone-forming tumor. This one's different. This is a so-called parosteal osteosarcoma, which is a low-grade surface-growing osteosarcoma. Typically prefers a posterior metaphysis, the distal femur, and it has the opposite of myositis ossificans, which has a zoning. This is this reversal of the zoning. What do I mean by that? Let's look at these. So we're going to get serial X-rays, okay? And this is a first film we're going to look at. Got two different guys here, okay? So this is one, this is the other, different patients. So first X-ray, we've got sort of a ring of calcium on the outside. This other one, we've got it starting in the middle, and then we go, and we go. All right, so, and we go. This here is the so-called zonal ossification, where it starts on the outside, and then it fills in. So what I want you to think about with this is you got a bruise on your leg, and you got a hematoma there, and the rim of the hematoma calcifies. You may have seen that before. And then slowly over time, it calcifies a little bit more and more and more and more as it works in. And that's different than this reverse zonal ossification, where something starts in the middle, moves out, moves out, moves out, moves out. That's bad. So myositis ossificans versus osteosarcoma is the poster boys for these two things. This one, so if you start out with a plain film that has some mineralization there and you're not sure, you can follow it over time. If it does this, then you're good to go, especially if you had a history of trauma. And if it does this, that's bad. Myositis ossificans is one of these don't touch lesions. You're supposedly not supposed to biopsy this thing. Pathologists suck at bone path, and you don't want somebody to end up getting their leg cut off because of a benign entity. All right, another one here, this versus that. So, big, bulky, bone-forming tumor versus this here. It's also a bone-forming tumor, but it's looking a little different. This here is your parosteal osteosarcoma, and this one here is your periosteal osteosarcoma. They're both surface growing, but the difference is when I say parosteal, I want you to think just big. Just think big. And they tend to involve both involve the same part of the leg. They like this distal femur. Parosteal sometimes more medial than parosteal, more posterior, periosteal more medial. Some people will say that this tends to be more diaphyseal versus metaphyseal. In my experience, they can be both places. The big thing to know about this is what I want you to take home. This is an older person. It is big and bulky, and it is low grade. So this has a better outcome than that. This one is a younger person, and some people say it tends to wrap around the bone. I think that's helpful. So bulky, wrap around the bone, and it has a better or has a worse prognosis than parosteal. Parosteal has a good prognosis, the bulky one. So let's talk about who does the worst, the worstest, the most worstest. So the most worstest of all time is secondary osteosarcomas. These are ones with like Paget's. Then the second most worstest is the classic type or the intramedullary type. And then periosteal and then parosteal last. And you may say, well, you skipped telangiectatic osteosarcoma. That one's somewhere in here. Most testable would be this one's the best prognosis. This one's the worst prognosis. Okay, so if you can remember anything, remember that. Best prognosis, the big one, the bulky one, slightly older patient. This is also an older one. This is the guy that had Paget's. All right, let's take a zoom in here. So this is something that I mentioned a little bit earlier where we've got an aggressive osseous lesion, wide zone of transition here, and it's in the diaphysis of the bone. It's a kid, right, open physes. So this is Ewing's. Permeative lesion, so buzzword, permeative lesion in the diaphysis of a kid is Ewing's. Notice that it does not form osteoid, so it's not a bone-forming tumor. It tends to be more permeative. Bone-forming tumor is osteosarcoma. It's rarer in African Americans, and the age is similar to osteosarcomas. So, forms osteoid, doesn't. Metaphysis, diaphysis. Mets to the bone and lung. Ewing's actually classically mets to the lung. Most common 10 to 20, most common less than 10. So this one's a little bit younger. It is still the same, there's an overlap in age group, but this one tends to be a little bit younger. This one goes bone to bone, so it has like skip lesions, and that's one of the reasons why you do staging MRI. Metaphysis, diaphysis, permeative lesion, bone-forming lesion, Codman's triangle, bulky starburst-looking stuff. Okay, next case. So this is an MR. This is an old. I'll tell you that this person is old. They're 60 or something, even though their discs look pretty good. And this is a very classic look. Some people say that this looks like a brain, a mini brain. So this is plasmacytoma, and which is it's a myeloma thing. Myeloma can have a whole bunch of different appearances, ranging from diffuse osteoporosis to punched out lesions, which is the one that most people are used to seeing, large solitary lesions. There is an entity called Poems syndrome, which is like, instead of having lytic lesions, they're sclerotic. That's the big thing to know about that. This is very hard to see on a bone scan. Plain film is actually better for it. Okay, next case. Scroll. We're going to scroll on this one. So, this is a T2 fat sat. Okay, scrolling. There. All right, so this is the picture right here. Freeze right here and take a look at that. That's what I want you to see. Super duper bright T2 midline. Okay, midline in the sacrum. So it's a chordoma. Chordomas are midline lesions. It's an embryological thing. It's midline. It only occurs in the midline. And so it can occur in the clivus. It can occur in the spinal column, midline. And it can occur in the sacrum. It does not occur in the iliac bone. Does not occur in the hip. Does not occur in the arm. Does not occur in the leg. Chordomas never, ever, 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 ever occur in the leg or in the arm or in the hip. They are midline, right up and down, midline lesions. They're T2 bright, and they're sort of locally aggressive. So, most common is actually the sacrum. Clivus is second most common. Remember that there's that differential in the clivus where if it's midline, it's a chordoma, and if it's off midline, it's a chondrosarc. You may have heard that before. Midline, 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 midline. C2 vertebral body is the third most common. You'll never pretty much see it anywhere else, especially for multiple choice. All right, next case. So this is a ball-like lesion. And this is really the best, probably, this may be the best case of this you'll ever see, because it's got all the good findings. So it's round, it's a ball, it's in an extremity, and it has 3 different colors, 3 different flavors. So this one, like a bright color, a gray color, and then a dark color. So some people will call that a triple sign. It's not a Baker's cyst. You see it more in younger people. So this is a soft tissue tumor, synovial sarcoma. It's common, and well, it's rare. It's common relative to sarcomas, in young people. Like extremity, it's a ball-shaped. It's younger, triple sign. So I said it's not a Baker's cyst, so where do Baker's cysts live? They live in a very specific location, and if they don't live there, they're not a Baker's cyst. So it's between the medial head of the gastroc and the semimembranosus. You have to know that. You have to know that. You have to know that for life. You have to know that for the test. Baker's cyst, medial head in the gastroc, semimembranosus, that's where they're at. If it's not there, it is a synovial sarcoma until proven otherwise, and you need to take them back and give GAD and stuff. Because, they can be T2 bright, but then you'll see like enhancing components. All right, next case. Now, notice that this one is, notice that it is more central. It's still in the leg, but it's almost in the hip. It's higher up on the thigh. Notice that it's less shaped like a ball. And I'll tell you that this is an older patient. So this is a malignant fibrous histiocytoma, which has another name now, pleomorphic undifferentiated sarcoma. I like to remember the fibrous part because it tends to have dark components on both T1 and T2, which makes more sense to me if I remember fibrous. It's very common, especially in older people. It tends to be more central relative to the synovial sarcoma. Think about this in the thigh or in the upper arm. Older persons, synovial sarcomas are younger people. Classic risk factors, Paget's and radiation. That's the big one, okay? Radiation. So for the purpose of multiple choice, I think this is all you need to know with regard to sarcomas. People are like, oh man, I don't know enough about soft tissue tumors and MSK. I think this is it right here, man. So liposarcomas are common. They have fat in them, obviously. If you see a retroperitoneal mass that's fat-containing, it's a liposarcoma until proven otherwise. The deeper they are and the bigger they are, the more likely they are to be liposarcomas relative to lipomas or atypical stuff that's in the middle. So something that's very superficial and simple looking and small is a lipoma. Something that's deeper, and as deep as you can go is the retroperitoneum. Any kind of complexity at all is some form of liposarcoma. Myxoliposarcomas are tricky because they can be they tend to be high T2. They can have like a mixed look to them, the myxoid look to them. It's sometimes hard to tell if that's a liposarc. I don't think that they will show that. I think if it's a liposarc, it will be obvious. They may do tricks like showing you fat sat or showing you in and out of phase imaging or something like that to show you that this is actually fat. The malignant fibrous histiocytoma, undifferentiated pleomorphic sarcoma. Think dark stuff, think central, think older person. And then by central, I mean like shoulder and proximal thigh. And then like synovial sarcoma, it's a ball, looks like a ball, triple sign, 3 different signal intensities. And then in the, it's going to be further down, like it's more distal. So like in the calf or in the foot, something like that. So, all right, now a couple more cases. Now these are sort of mimics for things that look like they should be bad, but they aren't. So what I'm showing here are these lines that go up and down here. There's one here, there's one here, there's one here, there's one here, there's one here. Striated almost. So this is osteopathic striatum. The only thing you need to know is that it doesn't mean shit. Just prominent vertical striations. This doesn't need followed. This doesn't need biopsy. This doesn't need any of that kind of stuff. It's just it doesn't mean anything. All right, here's another one. Bunch of these little sclerotic things, whole bunch of them, sort of look like bone islands. How do you know that's not Mets? 2 ways. One, does the patient have a history of Mets or prostate cancer or something that would have sclerotic Mets? And also notice that they're centered around the joint. So see how they're like right here at the joint, not seeing them here. Remember the metaphysis is the big blood flow thing? So like that's sort of where you would expect a Met to go from hematogenous spread. These things are sort of centered along the joint line. So what are they? They're actually a bunch of bone islands. How do you know they're not Mets? 1, they typically cluster around the joints. 2, they typically spare the axial skeleton. So we're not talking about this in the spine. Okay, so that's it. That's the end of this talk, and the next one will be a high-yield, rapid review of things that are MR topics.